All right. Hello, everybody. Welcome to Pediatric Grand Rounds. Today is one of our Frontiers in Child Health Research seminars, and it's my pleasure to introduce our speaker for this week, which is Dr. Andrea Garber. Dr. Garber is professor of pediatrics here at UCSF in the Division of Adolescent Medicine, and she directs our eating disorders program, she's the nutritional director for the program. She also serves as chief nutritionist for our leadership education and adolescent health training program. Dr. Garber's clinical trials have shaped international guidelines for nutritional rehabilitation in anorexia, including from the American Academy of Pediatrics and other leading medical societies. Today, she's going to discuss her emerging work on how body composition and the gut microbiome can guide a more personal approach to refeeding. And it's a pleasure to welcome Dr. Garber.
Okay, thank you very much. Thank you for coming. I'm so excited to have this chance to discuss our work, and it's so wonderful to see the friendly faces out here. So thank you all for coming. I thought for people who don't know me, it might be fun to do a little bit of introduction about myself. I did my doctoral work at University of Wisconsin-Madison. For those who don't know, that is a big nutrition school. A lot of the original vitamin studies were done on livestock, of course. This was back at the turn of the century. And in fact, some of the major discoveries, including vitamin D irradiation of milk and warfarin, which some of you physicians might be familiar with as a vitamin K antagonist, was also discovered and named after the Wisconsin Alumni Research Foundation. So this was my start. Here I am as a youngster. My advisor was John Suddy, shown here, and Dr. Suddy was a premier scholar in the field of vitamin K metabolism. And I convinced him that I wanted to be a clinical nutrition researcher. He was a biochemist. And he really supported me in doing my first clinical study. So all of the people in the prior slide were the victims for this study, and they gleefully signed up for $50 to get their blood drawn 9 times over the course of one day after eating a boatload of spinach. And then I compared the bioavailability of spinach to a tablet. And of course, you can see here that the spinach lost by a mile. So, but I was undeterred. And when I finished my PhD, I came to UCSF to do my dietetic internship, where I was very fortunate to join this group led by Charlie Irwin, you can see here. And these people really were, and many of them still are, the giants in the field of adolescent medicine. I was so lucky that Barbara Long found me. She convinced Charlie to hire me, and I had wonderful mentorship, and I still do, by Elizabeth Ozer and many other people in this picture, including Cherie Boyer, who mentored me in writing my first paper in adolescent health, and Barbara Maszewski and Marianne Schaefer, who were the co-investigators on my early study in refeeding in anorexia nervosa. So for today, I thought we would start with a quick history of short-term nutritional rehabilitation or refeeding in hospitalized patients with malnutrition secondary to eating disorders, and then fill you in on what we've learned about the quantity of refeeding and tell you where we're going now, considering the quality of refeeding. So again, so many people in this room take care of these patients, but for those who don't, just a quick reminder that patients with restrictive eating disorders are a very unique population with malnutrition. They have malnutrition secondary to a psychiatric diagnosis that is characterized by caloric restriction, overexercising, and other behaviors that result in weight loss. And it's considered to be uncomplicated malnutrition, just in the sense that it's not accompanied by infection or critical illness or cancer cachexia. But there are many endocrine adaptations that are seen that are directed at extending life in the face of starvation. So, for example, low leptin, which we'll talk about. But very generally, these patients come to our inpatient unit in a hypogonadal, hypometabolic state. Sometimes when we're meeting with parents to try to illustrate this, we use the image of hibernation, a hibernating bear, to just kind of give some sense around why their child is coming to us or their adolescent is coming to us with low heart rate, low temperature, low blood pressure. But that's really where the comparison ends, because of course humans are not cut out for hibernation. And so the teenagers that we treat quickly develop autonomic dysfunction and vital sign abnormalities that require hospitalization. And those are shown here. So these are the indications for hospitalization in adolescents and young adults with anorexia nervosa. The most common one is bradycardia, defined as heartbeat less than 50 waking or less than 45 overnight. The second most common one is orthostatic change in heart rate from lying to standing. But the reason I'm showing these, they'll make a comeback. We're using these as nutrition sensitive markers of refeeding efficacy. So if patients meet those criteria, they are admitted to the hospital for refeeding. And here's what it looks like. It's nothing fancy. It is simply bedside meals. And this is the standard of care internationally. There's really very few programs that are using tube feed. It's really a very meal-based process. Now, historically, refeeding recommendations were extremely conservative. And that came out of studies around the time of World War II that demonstrated the refeeding syndrome in response to renutrition in starved patients. The most famous one was the Minnesota experiment. You can see here two of the men who volunteered for that experiment. They were conscientious objectors to the war, and they underwent starvation and refeeding. And during that study, they Keyes and colleagues documented cardiac arrest, delirium, seizures, no deaths in that study, but there were deaths due to the refeeding syndrome that were documented in prisoners of war and subsequently, unfortunately, in patients with anorexia nervosa undergoing refeeding, just a handful of cases. But you can imagine that the field progressed with extreme caution after that, and all of the available recommendations shown here really recommended very low calorie diets. And in fact, in the UK, they started with as little as 500 calories per day for refeeding. Well, that took time. And as a result, the hospitalizations for these patients were long, they were intensive. And our own Naomi Bardock published a really nice paper placing eating disorders among the most common and costly primary mental health diagnoses in pediatrics. Furthermore, the outcomes were not good. So about half of patients were and still are readmitted within that first year after their initial hospitalization. And over the course of many psychotherapy clinical trials, only about 1/3 of patients with anorexia nervosa meet full clinical remission criteria at 1 year. So our question, our overarching research question has been, how can we optimize or improve these outcomes through nutritional rehabilitation? And in our early work, we were very focused on achieving this through weight gain. And the belief at that time was more weight gain will give you better outcomes. And that had been shown in many retrospective studies. In hospital, more weight gain predicted 1-year recovery. In outpatient psychotherapy, Daniel LaGrange and colleagues showed that more weight gain in the first 4 weeks was associated with clinical remission at the end of treatment. And Angela Garda and colleagues published a study showing that weight restoration would be, quote unquote, half price if you could double the speed of the weight gain. So we started looking at this in 2002, back, if anyone remembers, when the PCRC was over at Moffitt Long Hospital. And we enrolled patients to observe them. So this was an observational longitudinal study. And what you can see here are our initial findings in our first group over the number of days that they were in the hospital and their weight change shown here on the x-axis. And what we found is that patients who were started here on an average of 1,100 calories, their length of stay was almost 18 days. They initially lost significant weight during the hospitalization, and we did not see any significant increase in their weight until day 8. Now, during this time, Sarah Buckaloo joined the faculty. She finished her fellowship. She was very interested in refeeding also, and started sort of nudging gentle elbows to her new colleagues to speed things up. And she was very successful actually in this regard, because we were able to enroll a second group and stage a sort of natural experiment comparing the low calorie group to the high calorie group. So here you can see a group starting more almost at 1,800 calories. And what we observed is that that initial weight loss was avoided altogether, and that weight gain was significant as soon as 4 days, and patients went home 6 days earlier. So we applied to the NIH for funding for our first clinical trial, and that was called the STRONG trial, aptly named by Dr. Accurso, the study of refeeding to optimize inpatient gains. And this was a multi-center study between us and Neville Golden's team at Stanford. So who did we enroll in this study? You can see here a comparison among the 120 young people that we enrolled, adolescents and young adults. They were diagnosed with both anorexia nervosa and atypical anorexia nervosa. Now, when we were proposing the study in 2013, atypical anorexia nervosa was a brand new diagnosis, and we really did not know what to expect. We knew that that new category had been created to diagnose young people who had all of the features of anorexia nervosa, but they were not underweight. And sure enough, you can see here in the green rows that by very definition of atypical, the only significant difference between these two diagnoses is that the patients with atypical were 95% of median BMI at baseline, so they were around normal still, and they had started slightly technically on the overweight side, although a large proportion of them were really normal, just on the upside of the median. But other than that, in every parameter that we studied, and I'm only showing a few here, they were just as hypogonadal, indicated by the presence of amenorrhea. They had lost a similar percentage of their body mass, and they had similar vital sign abnormalities. They were just as bradycardic, just as orthostatic. And Jason Nagata subsequently published a really nice study. Of course, his study sample, I think, was like 450 young people, just reinforcing the same concept that typical and atypical patients with anorexia nervosa look very similar in terms of their illness severity. So from there at baseline, we then randomized them to one of two treatments, either the test group, which was high calorie refeeding, shown here, starting at 2,000 calories per day and increasing by 200 calories every day, or the low calorie group, starting at 1,400 calories, to purposely designed to avoid that initial weight loss, and then stepping up slowly by 200 calories every other day. We collected data every day in hospital. We had a standardized electrolyte replacement protocol so that we could track safety, and electrolytes were drawn every day for this first 7 days. And then we had 5 follow-up time points over the subsequent year. And here are the results. This is a survival analysis, goes the opposite direction from what you're used to, because what it's showing is how the two groups step upward toward medical stability. So remember, I said those vital sign abnormalities, those were present when the patients were admitted, and then we watched the amount of time that it took in order for those to fully reverse. And you can see that the higher calorie feeding group got there faster. And here's another way to look at that. Medical stability was restored 3 days earlier in the high calorie group. Bradycardia reversed 4 days earlier. Weight gain was 0.8 kilos higher. Length of stay was 4 days shorter. And our health economist, Leslie Wilson, reported to us, or helped us report, that it saved almost $20,000 per participant. And then importantly, especially for the physicians who we were trying to translate this work for, there was no difference in the occurrence of hypophosphatemia, which is the hallmark risk factor for the refeeding syndrome, between the two groups. over time, Neville Golden published the 12-month follow-up showing there was no difference between HCR and LCR groups. So the way that we interpret this is that no difference long-term indicates that the short-term findings were sustained. And then two more very important pieces toward the translation of this work. One was from Aaron Accurso, who reported that HCR does not increase mealtime distress. And a second study by Sasha Gorel showing that HCR does not erode parental self-efficacy to restore weight. Now, these were really important, perhaps even more important than the electrolyte findings, because when we started this work, Sarah and I experienced some real shock from colleagues in the field who said, you know, this is tantamount to gavage feeding, and it's, oh, you know, you're going to create a revolving door where patients are just going to be pushed out of the hospital and come right back. And that was legitimate, that there was a lot of concern about how fast we were proposing to go. So these studies really helped enormously to translate the work. And we're proud to say now, if you look at recommendations for refeeding worldwide, they do reflect the data from our trial here. So in Germany, in the UK, in the US, and even physician-facing references like UpToDate and Medscape reference these findings. So, of course, we can't be too busy patting ourselves on the back, because what we produced through these findings was a step forward, but it was still a one-size-fits-all approach. So we're coming out with to say, well, 2,000 calories now is the new standard of care. But like everything that's one-size-fits-all, you know, it ends up not really fitting anyone well. So our first step then was to look at who does not respond to high-calorie refeeding. And what I'm showing you here is the same survival analysis, only this time in a 2x2. So there are two groups, low calorie and high calorie, and two groups, low calorie AN and low calorie, high calorie atypical AN. I'm not sure if I explained that well, but there are four groups is what I'm trying to say. Now, same as what I showed you before, patients who had typical AN and were refed on high calories did well. They stepped up sooner. But patients with atypical AN, even when they were treated with high calories, they lagged behind. In fact, you can't even distinguish them here from the patients who received the low calorie treatment. And what we thought, because we had been so focused on body weight, is we believe, okay, well, let's look at the dosage. If we look in terms of kcals per kilogram, just by nature of the atypical patients being larger size, they're receiving a lower dose. So the optimal dose in these low weight patients was 50 kcals per kilogram. And patients with atypical only received 32 kcals per kilogram, even when they were on the high calorie treatment. And in exploratory moderator analyses, we found evidence for increasing calories and better outcomes. So theoretically, if we increased calories by 10 kcal per kilo, we could hasten the heart rate recovery, boost the weight gain, and shorten the length of stay. And based on that, we started our current clinical trial, which is the iStrong trial, same name, only now I for individualized, where we individualize the dietary treatments based on body weight. And that was the primary aim of this trial, was to look at the efficacy comparing the 50 kcal, the so-called optimal dose, to what had become our current standard of care, the high calorie refeeding group. The third aim, and then the second aim was safety, of course. The third aim of the study is probably the one that will yield the most interesting results, because that one was really our effort to get away from this intense focus on weight gain, weight gain, weight gain. And so we included a lot of measures shown here that would provide other benchmarks or other metrics for recovery and for metabolic recovery that could be separated out from the effect of weight. So the hormonal markers are listed here. You can see resumption of menses, estradiol, luteinizing hormone, follicle stimulating hormone, testosterone in boys, cortisol, and T3. In terms of metabolic markers, we performed indirect calorimetry, and T3 is on there twice as both a hormonal and a metabolic marker, leptin levels. And then Aaron Accurso added a really interesting battery of psychological testing to look at things that had not been explored in patients with atypical AN, such as internalized weight bias. And here are the results. Now, these are hot off the presses. So I put this little like no camera as if anyone would be so excited that they would be like tweeting this out, you know. But I think I'm overselling here because what I'm showing you, what I'm about to show you, brace yourselves, is no effect. So first, let's just do a little fidelity check. Did the individualized group receive more calories? Yes, they did. So at least we succeeded there. You can see they started on 530 more calories than the HCR group. They left the hospital on over 300 more calories per day. So they did receive a significantly higher caloric load than the standard group. Here you can see the change in metabolic markers. And again, in terms of a physiologic check, you can see the refeeding process worked. These patients had significant decreases in cortisol, increased T3, leptin, resting metabolic rate, and weight gain were all increased across the whole group. But we saw no difference in the changes in these metabolic markers between the two refeeding arms. So what we're concluding here is that this extra high calorie feeding is not providing a metabolic benefit that we can see in the hospital. And similarly, if you compare the two groups by treatment outcomes, it does appear here. Now, Sasha Garel will get mad at me when I play fast and loose with my p-values, but I think the ICR group tended to gain more weight. It's almost a kilo more of weight gain, which makes sense. They were on a lot more calories, but we do not see that translating into any kind of a benefit for hospital outcomes. They did not stabilize faster in terms of overall medical stability. Their heart rate did not turn around faster, and they did not leave the hospital faster. So where does that leave us? My feeling is that coming out of the second trial, we have entered the dreaded yellow zone of diminishing returns. In the original STRONG study, I feel like we were in that green zone where every time we increased and we looked over the patients, increased calories really gave us some great benefits in related to weight gain and shortening length of stay. But after we passed that HCR mark, we're really just not seeing a benefit of adding more calories. Now, there's certainly more work to be done, as Aaron has pointed out, looking at individual responders and non-responders. But just in general, the feeling is that we've reached this point. So why might that be? And that's where I really want to focus now in the second half of this talk is once you've reached the limit on the quantity, you really have to start focusing on the quality. It's about time. Okay. So in terms of the quality of weight, I just told you that the patients on the ICR group gained what looked like almost more weight, but there was no metabolic benefit. Why is that? We've been focused for a long time on treating the human body as one unit, right? Body mass. We take weight, we calculate BMI, we have a few other metrics, we do fancy Z-scores, but it still treats the human body as a single unit. And the evidence that has emerged over the past few years shows that even if you split the human body into two units, you can get a lot more information about hospital outcomes. So just by taking body composition and splitting it into fat mass versus fat-free mass, in fact, you can predict hospital outcomes. And these are now the basis for the inclusion of body composition as a criterion for diagnosing malnutrition in the new global criteria. So the studies to support that show that low fat-free mass, when this compartment is reduced, independent of BMI, it predicts poor physical function, it predicts mortality in hospitalized patients, and it predicts in children complications in hospital as well as longer length of stay. So notice how fat mass is not predictive. And I think that's a really interesting thing to keep in mind when we're thinking about our patients with atypical AN. It's not that we don't care about fat mass, but it's their lean mass that is really driving their risk. So why don't we just leave it there? and focus on fat-free mass? Well, because fat-free mass is an extremely heterogeneous compartment. And in fact, fat-free mass contains a little bit of adipose tissue. There is lean connective tissue in adipose. It contains all of the bone mineral. It contains the skeletal muscle mass, contains the brain, and all of the other organs in this so-called organ residual compartment. And if you want to really get at the underlying physiology that is driving these outcomes, you have to understand which compartment you're looking at. So there has been a very nice study using DEXA, looking at how these compartments change in anorexia nervosa. Now, this is an extreme case. The study by Comiskey et al. Was done at the Denver Acute Center, which treats patients with so-called extreme anorexia nervosa. These are patients who are average age 28 and 81 pounds with long duration of anorexia nervosa. But I think it really illustrates the stark contrast. What you can see here is that in response to extreme long duration starvation, adipose tissue is decreased by 69%. Bone is diminished by 18%, skeletal muscle mass by 21%. Brain volume does decrease in response to extreme malnutrition, but it's not captured by DEXA. So that's why I put the arrow, but I said, I have to admit, we're not measuring it there. And then organ residual mass is diminished by 25%. So a couple things to notice here. First of all, that protein is mobilized, protein is mobilized equally from the skeletal muscle mass and from the organ residual mass. Now, evolutionarily, that's really interesting, right? Because during starvation, if you totally decimated your skeletal muscle mass, you wouldn't be able to like chase down the antelope when it crossed your cave. Or on the other hand, if you totally decimated your visceral mass, you'd be too metabolically and medically unstable to eat, I guess, to chase the antelope. So the idea is that the body is drawing protein, catabolizing proteins equally from these two compartments. Now, the other thing to notice is that if you think about the anorexia nervosa literature, almost all the studies we have to date are focusing on these compartments. We know a lot about fat mass and long-term amenorrhea and bone health and osteopenia. We also know a lot about skeletal muscle mass and impaired physical function over time. But this compartment, the organ residual mass, really has received very little attention. And we're interested in it because if you think of it from an organ system model developed by Hemsfield and colleagues, the ORM is the metabolic system. It contains the liver, the heart, the kidneys, the spleen, the GI, the blood. And that is the system that is tasked with digesting and metabolizing the refeeding load. It's tasked with restoring the hemodynamic stability and has an important job to do during refeeding. And I just showed you it's just as decimated as the skeletal muscle mass. And in fact, in that past study, I forgot to mention the absolute amount of visceral mass that was lost is 4 kilograms, if you can imagine. And that finding has been repeated in mixed method studies using MRI, CT, DEXA, and ultrasound. So how the heck are we going to measure this? Even if we could get our kids to DEXA, which by the way, we can't, it's a pain. And it's difficult to get them there because they're medically unstable. The current recommendations for densitometry are a limit of about 2 DEXAs per year in children and adolescents. So if we really want to, which we do want to, track body composition over time, we need a better way. And that's where Amanda Downey comes in. And here is her pilot study that was funded by our NORC here at UCSF through RAP. And what she did is she used 3-dimensional optical imaging to capture body composition during refeeding. And you can see here's the A team. This is Sienna. She's doing her PhD at USF. Here's Nadia Bordad. She's here, who has been schlepping this scanner around from room to room, aided by Arjun Mehta. But here's the scanner. It's designed to be portable. And in fact, this came out of a collaboration with the Shape Up investigators when John Shepard was here. If anybody remembers him, I started working with him in 2013, and he's since gone to University of Hawaii. But this scanning equipment kept getting smaller and smaller and smaller. Part of the impetus was for space flight, to track bone composition during space flight and have portable equipment. So Amanda used it, though, to track changes in body composition during refeeding. And you can see here just a really basic image. Here's a DEXA image that you're all used to seeing on the left, and on the right side is the mesh that is created by a 3D scanner. And there have been dozens of studies now validating 3DO against DEXA, against MRI, and other criterion measures. And we did one study to actually show that it performs well against DEXA in low BMI patients, including our patients with eating disorders. So just to highlight one of Amanda's results, the one that I love the best because it supports our working hypothesis, what she showed is that from pre to post refeeding, there is no average increase in that organ residual compartment, but over the spread of her 20 pilot subjects so far, you can see that the amount of organ residual mass that was increased was significantly associated with the amount of heart rate improvement. So this does support, or at least our working hypothesis that this organ residual mass compartment is important for medical stabilization. So wouldn't it be great if we knew how to refeed that compartment, target that compartment? Unfortunately, we don't yet, but we're trying to learn. And in fact, what we do see clinically, and this has played out experimentally, as you can see here, is that we're much better at refeeding the adipose tissue. Whether we like it or not, this is a long-standing finding. In fact, it's so long-standing that the data I'm showing you here come from the KEYS study. And what I'm showing you here is that during the weight loss phase, both lean mass and fat mass are lost. Now, in a perfect world, both of those compartments would increase back to baseline during the refeeding phase, but that is not what happens. What happens is this blue dotted line where fat increase ramps up quickly, and it in fact overshoots the baseline, and lean mass accrual lags behind. And people are calling this the fat overshoot. These data were just republished. I took this from a 2018 paper, but now that so many patients are coming off of their GLP-1 agonists, this is a huge area of interest again. So you're going to see fat overshooting all over the place now, starting now. Okay. So to really understand these differential effects on body composition, we have to go back to diet. You know, that's my bias as a nutritionist, right? You know, this was all coming back to diet, but I really believe that this holds some very valuable information in understanding what's happening during the refeeding process. Not just what we're feeding the host, but what we are feeding the microbiome. So if anyone feels kind of like cringy about calling our patients the host, I always feel a little bit that way too. Just remember that we humans cannot digest dietary fiber at all. Only our microbes do it for us. Okay. So where did this idea start? It starts back around 2005, 2006, this idea that the gut microbiome could be a novel target for precision nutrition in refeeding and anorexia nervosa. The early studies, in fact, one of the seminal studies led by Peter Turnbaugh, who's now here at UCSF and who analyzed our stool samples for us, I'll tell you in a minute, but those were using germ-free mice, and looking at what happens when you transplant feces from either conventionally raised mice or obese mice. And what they showed is that germ-free mice, which are notoriously lean, very difficult to get them to gain weight, once they had the fecal transplant and they introduced a normal microbiota or the obese microbiota, they gained up to 60% fat mass. The second observation comes from studies of children in developing nations, which suffer from chronic malnutrition and chronic low weight and infection. And in those children, even following nutritional rehabilitation, they had persistent gut dysbiosis that was linked to poor learning or learning difficulties and persistent rates of infection. The third observation now comes from in 2015, 2016, some studies from Susan Kleiman and Cindy Bulick and Isabella Mack connecting gut dysbiosis to anorexia nervosa. And what they showed is that there are significant changes in the gut microbiome in patients with anorexia nervosa, and that those changes are linked to eating disorder psychopathology, as well as the GI distress that we see in our patients, namely delayed gastric emptying and early satiety. So finally, a really interesting study in 2021, also using germ-free mice, performed a human transplant. So in human subjects who had undergone caloric restriction, fecal transplants into germ-free mice actually transferred resistance to weight gain. So this idea, it promotes this idea that the gut can become resistant or can remodel in the face of caloric restriction. And in fact, that can be then passed on. So with that background, I want to talk a little bit about our microbiome a pilot study. And to do that, we have to start with what is going on in the healthy gut. Now, I hope your brains are not hurting just even looking at these metabolic cycles. You learned these in school at some point. You thought you were done with them, but I love this stuff. So in the healthy gut and the healthy host, remember I said that we humans cannot break down dietary fiber. So dietary fiber enters the system. The microbes break it down. The major byproducts of that bacterial fermentation are short-chain fatty acids. And what I'm highlighting here are two of them, butyrate and acetate. But there's a third one that's important, propionate, that's not shown here. But these short-chain fatty acids are really important for human energy metabolism. In fact, you'll be glad to know that they provide 10% of your daily energy requirements. They also are very important modulators of appetite and energy balance via neuroendocrine signals, including GLP-1, also PYY and leptin. So in general, a healthy gut and healthy microbes through these short chain fatty acids promote a state of fat oxidation, so fat burning, high energy metabolism or high energy burning. They suppress de novo lipogenesis, and they promote insulin sensitivity in all of these targets shown here. So they interact with the adipose tissue, the liver, but also not shown here. They interact with the skeletal muscle, with the pancreas, and they even cross the blood-brain barrier. So this, in fact, if you think about it, is really the, all of these good mechanisms that I just described, insulin sensitivity and energy expenditure, are really the basis or the underpinnings of why a diet high in fruits and vegetables and whole grain has such enduring health effects. Okay.
Code blue, adult, hospital, main entrance, exterior. Code blue, adult, hospital, exterior, main entrance. Code blue, adult, hospital, exterior, main entrance. Code blue, adult, hospital, exterior, main entrance.
Okay, so just to wrap up this slide on the healthy gut, I did want to note that among these short chain fatty acids, butyrate is the preferred fuel for the colonocytes. And so most of the butyrate that is produced, 90% of it is consumed by the colon, keeping your colon healthy and happy, maintaining a good barrier to prevent infection and to tamp down inflammation. Now, in the starved gut, one reproducible finding across all of the subsequent studies that have been done in anorexia nervosa is decreased short-chain fatty acid production, specifically decrease in taxa that produce butyrate and decreased butyrate concentrations in the feces, only one study showing decreased concentrations of butyrate in the serum. In addition, there are findings in patients with anorexia nervosa that acetate producers proliferate during starvation, specifically mucin degraders. And those are taxa that can actually eat away at the mucin lining here in the absence of dietary substrate. So how might this be a survival advantage? Well, when butyrate is scarce, and this pathway B is the major butyrate production pathway, acetate builds up. And this acetate, because it's not consumed by the colonocytes, can go directly into the portal circulation where it's delivered to the liver to rescue metabolic cycles. So this has a protein sparing effect, at least in rodent studies, has a protein sparing effect during starvation. And that's our working hypothesis for this microbiome sub-study, is that the shift toward acetate production in the starved state, it may be lending fuel to the host, even though it's occurring at the expense of the gut. So we ask, does fuel shifting impact metabolic recovery during refeeding? Like I said, there is evidence in rodent models that microbial acetate promotes parasympathetic activation, specifically low heart rate. And during refeeding, it contributes to hyperinsulinemia, hyperphagia, and lipogenesis. Now, like I said, in anorexia nervosa, there's no direct evidence yet that acetate levels in the serum are increased. However, we know that our patients have bradycardia. That's the most common medical instability. And we know that insulin resistance and central fat accumulation are major problems during refeeding, major challenges. So in our sub-study, we took stool from 30 participants in the iStrong study. So we took stool upon admission and upon discharge. We sent some stool to the Turnball lab where they burned it in a bomb calorimeter to find out how much energy was left in the stool. And that's a measure of energy density. So more energy in your stool indicates that the gut is less efficient at harvesting that energy. Okay. We then sent samples to the metagenomics core. And I did want to just make a note, if anyone is interested in getting into microbiome work, the Benioff Center for Microbiome and Medicine is fantastic. We've done so many wonderful things there. And this work was supported by a pilot grant from them. So the metagenomics core measured beta diversity for us. And the way that I came to understand this is just asking, when you sequence the ribosomal RNA, it's simply asking who is there. We don't know what the microbes are doing. We're just asking at this point, what's the composition and who is present? Then we did differential abundance to look at changes in the composition, and fuel classification to label the taxa that we detected as either acetate producers or butyrate producers. So let me show you our first result. The first result that you're seeing here is the association between increasing taxa, shown in orange, and decreasing taxa, shown in green, in relation to lower baseline BMI. And what you can see here, and this part is qualitative, is that out of 167 taxa that were detected, the only 4 that were significantly increased are all acetate producers. And the next slide is also a differential abundance analysis, again, asking what taxa are increased or decreased in relation to now poor energy harvest. And what you can see, the size of the bars indicates the effect size, that the 4 largest increases in relation to poor energy harvest are all acetate producers. So this begins to provide some qualitative evidence that we are seeing that shift toward acetate in relation to the degree of malnutrition at hospital admission. Now, hopefully you're asking yourselves, okay, well, what happens during refeeding? These data you saw before here on this table, this just shows the warming up or the increase in metabolic markers over the course of refeeding. But what I added now is energy harvest. And you can see here that we saw a significant increase, an improvement in energy harvest over the course of refeeding that is lined up with all of these other improvements, metabolic improvements. And secondarily, you can see here that those metabolic improvements correlated with the shift in beta diversity from pre to post refeeding. So what this suggests is that the gut microbes are restructuring during the refeeding process, and they're restructuring in alignment with metabolic recovery. And so finally, I just wanted to show that in terms of this restructuring, we looked at then over the hundreds of taxa that changed from pre to post refeeding, which ones were significantly increased and decreased when you adjust for the number of calories received. So this is differential abundance analysis anchored in a metabolic marker. And what you can see here is that of those hundreds of taxa that increased, the 3 that were significant were butyrate producers. And out of the 7 that decreased, 5 of them were acetate producers. So what this suggests is that that shift, that fuel shift toward acetate production that we saw in the starved state starts to reverse over the course of refeeding. Okay, now, if this is true, and that's a big if because this is preliminary and we have a long way to go here, but if it is true, then it reveals potentially a target for microbially directed diets. And we have a perfect opportunity because they're stuck in the hospital with us for 8 to 10 days, and we're feeding them anyway. And so we did an analysis of our current diet, and what we find is, I want to state first to start that we provide very high quality food at our hospital. There's no doubt about that. The food is nice. There are a lot of interesting selections as well, and it meets generally macronutrient and micronutrient needs. But the one thing we found is that the fiber content is low. So we analyzed our 2-week menu cycle, and what we found is that our hospital food is providing about 8.4 grams of fiber per 1,000 calories. The current dietary guidelines call for 14 grams per 1,000 calories. So there's improvement that can be made there. And this is important because diets that are high in refined starch, particularly simple sugars like fructose and glucose, those are acetate driving diets. And that has been shown in animal feed studies where they can really manipulate the content of the food, but also in humans. A butyrate supporting diet is a diet that contains a lot more resistant starches. So fruits, vegetables, whole grains, and then root vegetables as well, like onions and garlic. So how the heck are you going to deliver a high fiber diet in the hospital? So I just made a quick comparison here to wrap things up. Here are 2 actual menu items from our current menu. I said we provide high quality food. Look at that. The meatloaf is actually grass-fed meatloaf. And they have a grilled tuna sandwich, which sounds fantastic. I would eat that for lunch. And what you can see here is that our current hospital food is meeting the mark on energy density. Our patients, remember, they struggle with gastrointestinal distress. So they need as much energy as possible in the smallest package that you can provide it. So they need raisins, not grapes. And although we hit the mark on energy density, you could see the fiber is really pretty low. That's the blue bar. Now, typical nutrition counseling would say, okay, you need more fiber, so you should have yourself a chicken salad and a grilled chicken salad and a fruit salad or a low-fat yogurt. And what that does is it flips this on its head. So it provides more fiber and it decreases the energy density. It provides more volume. That's probably good for all of us. But what our patients need is they need both. And so we pulled some examples of foods that provide both from this really interesting study that was done in Singapore at a hawker market. And they had all of these different foods that they analyzed for energy density and fiber, and just put a few examples here, but I'll call out like my favorites, saag paneer, dal, chana masala. And you notice a pattern here. These are vegetable-based, but very high fat, delicious dishes that are made with either whole grains or beans. And here you can start to see that the foods hit the mark for both high fiber and high energy density. And then we looked at also, what about, these are teenagers after all, so we have to provide some so-called American foods as well. And the examples there would be like guacamole with whole grain chips, or a good old-fashioned peanut butter and jelly sandwich on a true whole grain bread. Okay, so just my final slide here to wrap things up. What do we think we've learned so far? Well, so far, we finally starting to believe that the quantity of calories and weight gain has reached a limit of diminishing returns. And that quality really should become our focus now. We have some evidence of a microbial fuel shift that is consistent with prior studies in anorexia nervosa, and some evidence that we can partially reverse that with refeeding, which suggests that it might be a ripe target for precision nutrition interventions. And there's a lot of work to do, so I'll skip over the next steps and we can discuss at another time. I want to thank everybody. There's so many people to thank. This is truly interdisciplinary work. So many people from medicine, nursing, nutrition, social work have taken care of these patients. But here I'm listing the investigators from the iStrong study, the microbiome investigators, and the body composition investigators, and our funders, of course. And then just to show us actually having fun doing the work. So thank you, everyone, and thank you for coming. I'm glad to take questions.
If you can repeat the question.
Yeah.
And the
I probably owe Elizabeth a coffee for that comment. Thank you.
Andrea, I've got it.
Yes.
So I was wondering what comes first? Microbiome.
So that's the question is what comes first, the gut dysbiosis or the anorexia nervosa? It's a chicken or egg. It's an excellent question. And I can't answer it, but just to say that is a real, a very hot area of research. And in fact, there is a call out for proposals right now from a foundation looking at exactly that, like the fetal origins, so to speak, of anorexia nervosa, looking at the infant microbiome and how that may contribute. So stay tuned. We're getting our patients, a little bit on the late side because they're already coming to us with malnutrition. But I will say that whether there are some pre-existing changes that could be targeted, the malnutrition certainly does a hit to the microbiome. So it's not helping whatever was pre-existing.
You have an online question for the great talk. In addition to energy metabolism, different microbes can also make transmitters. Are you looking at other metabolic products in your
Great question. We would love to. We would love to. So please email me and we will add them in. We're looking for money right now to do, we're applying for money for grants to, so I wasn't going to pass it out a hat, but I might. But we're applying for grants right now to do metabolomics and look at different fecal metabolites for sure.
So Jim, bring money and
yes, bring your wallet
and your neurotransmitter.
Right. Yeah.
I have a question, which is just maybe not as related, but testosterone levels drop in males with anorexia.
Yes.
And how do they recover?
Yes, so good question. Low testosterone levels are part of that hypogonadal state, and we certainly do see that. We didn't have enough boys yet to really draw a conclusion, but we can look among like our 5 or 6 boys that we had to see if they show a significant increase. But certainly the literature supports low testosterone in the starved state and an improvement with weight recovery.
And is that associated with any other physiologic manifestations like?
Boy, where's Jason when you need him? Jason Nagata.
I think he's away or something.
Yeah.
I remember something in the email.
He's really developed the literature on anorexia nervosa and atypical in boys, and he would know what the other clinical features are. But I will say it co-occurs with the clinical features that we measure, for example, bradycardia and and orthostasis and so on. Those all fall in line with the low testosterone. But in terms of what other like clinical or functional features, like reproductive features, I don't know.
I mean, you have decreased libido, you can have decreased menstrual conditions, just decreased frequency of erections, which your 13 to 14-year-old boys may not necessarily. It's worried about.
Mm-hmm, mm-hmm. Do I have to repeat all of those things? I'm out of my comfort zone. Okay. Well, thank you so much. Thank you, everyone.